Well, welcome everyone to our Quality Cafe. This is session 10. I can't believe we've done 10 of these. This is number 10. I can't believe we've done 9 of these. But today we're gonna talk about our healthEconnect, the Alaska's HIE, and I have Kendra and Carlin here from healthEconnect to talk to us. Just a little reminder of what the Quality Cafe is. Each cafe includes a 20 to 30-minute learning session followed by a question and answer. It's open to anyone interested in the topic, and the goal is to foster networking and shared learning amongst our quality professionals in Alaska. And we're currently meeting every 2 months. We did skip the last one because we were getting ready for our April Quality Summit. Here are our previous 9 sessions and their topics. We have all the recordings, so if you're interested in them, just send Debbie or myself an email and we'll forward the links to you so you can have them. And with that, I'm going to turn this over to Kendra and Carlin. So I'm going to stop sharing and let them share their screens. And
Sounds great. I will start. Carlin's going to load up the presentation. She's going to drive for us today, so we don't have to flip back and forth. So my name is Kendra Sticka. I'm the Executive Director at healthEconnect Alaska. Carlin Evanoff is our Director of Clinical Informatics. So we'll do a little tag team here to talk through some of the basics of healthEconnect and the HIE, and then hopefully have some time for, definitely have some time for questions as we move through. So first of all, thanks for joining. Really appreciate it. Always appreciate the opportunity to share about the HIE and some of the capabilities. We put some learning objectives here just to kind of give a sense what we're intending to cover today. There are so many things that the HIE can do. So really trying to focus in on some things that in particular in the area of quality that might be of interest and might be a little bit new if you are familiar with the HIE. We are definitely moving into different spaces and have some different tools. So I want to make sure people know that functionality. So we'll talk through that a bit. So I am going to kind of the learning objectives. I'm going to start with what the HIE is. I will try and be quick. So most of you probably know this, but there's always usually someone who is not familiar at all. So definitely we'll talk through that in a minute. We'll also kind of give some information about how you can see what organizations are participating in the HIE, which will give you a sense of the data in there. And this slide will populate in just a minute. It will be blank, but it will come on in a minute. So, and then we're going to focus on a couple of tools of the HIE that are particular around population health and especially around social deterrence of health, knowing that that's an area that I think people are really continuing to figure out how to best do this. Carlin, it's fine to pop to the next slide if this one doesn't seem to be doing its thing. It was a really cool image of how the health information exchange works. But so in terms of kind of that, but we'll talk about social determinants of health, data and tools in the HIE for that. And then really kind of hopefully have you have some brain ticklers about how the HIE might be useful for your organization. And then we're always happy to follow up individually to do a little bit of a focus demo on a tool or capability that might be of interest to you. So before we hop to this slide, just the one that didn't pop up as I thought it was going to, but just the Health Information Exchange. So healthEconnect is Alaska's, we are a nonprofit, independent nonprofit entity, but we have a contract with the state to be the state designated Health Information Exchange. So essentially we help data move from all the different electronic health record systems into a central data repository and then be viewable based on patient relationships. So an organization, even if one of their patients had care outside of their organization, they would be able to see information about that care in the HIE. So really the goal is to improve the efficiency and effectiveness of care and the cost of care in Alaska. So really established as a public good for Alaska. And I think that's a really important point of who we are as a nonprofit, because serving as a public good, probably our biggest, probably most critical role in my view, is to really partner with you all in terms of how do we shape this thing for the good of Alaska. And so we always appreciate engaging and hearing feedback. And as we're doing Q&A today, always happy to hear ideas or what would be useful as we look towards new use cases. So this slide is approved uses of the HIE. Because we serve as the state designated HIE, statute drives what we are allowed to do with data. And I think that one of the values of this is that it also gives a lot of confidence in how data can and can't be used when you're accessing the HIE. So I think that sort of sets it different than some other data sharing in that it's, statute drives how that's used. So really the 4 primary allowable uses by statute are for care coordination. So that's a lot of, I think, where we're seeing some increased growth in utilization. How do we really help patients get more coordinated care, more cohesive care, where they're getting what they need, when they need it, not having duplicative services, that kind of thing. So care coordination is an important approved use. And I think we have some new tools that help with that as well. Treatment, I would say that's probably one of the first use cases of health information exchanges. So really thinking about that point of care, a provider accessing data. The classic, someone lands in the emergency room and you know nothing about them, and you actually have some information about their medications, their allergies, their past medical history, so that you can provide safe and effective care in that moment. So treatment is definitely an important use case as well. Billing, so this relates to payers' relationship with the patient. So payers can use data in the HIE on their patients. Everything in the HIE is, again, based on that patient relationship. So nobody can say, hey, I want to know all the patients in the HIE who have, X disease. It has to be based on the patient relationship. But payers have that capacity too, which can help them in their work and help that interface between providers and payers as well. And then public health, the public health use case, I think, is also important to sort of articulate that it doesn't mean that public health or the state of Alaska has access to everything in the HIE. They have access to the HIE as a tool to access data that they already have a legal reason to see. So for example, reportable conditions or that type of thing. But the HIE can provide a very efficient mechanism for them to get that data and for organizations to provide that data for those public health use cases. So these approved uses are, again, driven by statute, and they really drive what data from the HIE can and can't be used for as we're looking at different use cases. On the next slide, we have a screen capture of our website. So typically, if people are looking at using the HIE, it's like, well, what data exists in there? Who is sending data? What am I going to find? And so this is an area that I think we continue to work to grow, although we are getting where there is a solid data set. We don't have complete coverage in the state, but we have a good amount of data to where we can use some of those more robust population health tools in a really meaningful way. Or you all can use them in a meaningful way. We can have the data there, you can use them in a meaningful way. So we'll talk about that today. But just a couple things on this slide. Again, our website, healthEconnectAK.org, there's a link that's called Our Network. So if you go there, you will see I have a portion of the screen snippet on the, I feel like Carlin's helping me like Vanna White thing, like here on the, no, sorry. But maybe that's, been gone a while, but anyway, okay. Back to healthEconnect. The network participants list, a little bit explanation on that. This is just a snippet of part of the list, but I think it's worth mentioning that we broke this down and gave a little more detail on the website that maybe doesn't make sense to everybody, but it gives you a little bit more data than just the name of the organization. So ADTs are admission, discharge, transfer. You probably all are familiar with that. So sort of a very basic core data set that most organizations, that's where you're going to see the most data in those. It's basic, but it gives some really critical information. And for some of the things we're talking about today in terms of population health, that feeds really great data in for us. CCDAs are a continuity of care document. Again, you all are probably familiar with some of these. Some organizations send those, which gives us sort of that next level of data that we can do a little bit more with. And then we have labs, radiology reports, not actual images at this time, but radiology reports, and then transcription, which would be transcribed notes, for example, from a discharge note or a clinical note from a facility. So this website will give you a little bit more nuanced information in terms of what organizations are sending what data. We continue to build this, so it changes and it evolves as we're able to work with organizations on the data that they would like to send and continue to work on building a robust data repository, because that's what makes it most efficient or effective, I guess. So that's on the website. And again, we're always happy to talk through details of specific organizations if you're trying to figure out how that would work for you. We are also always happy to hear if there's an organization that is not on that list that would be really valuable for you to have data sharing with. We're happy to do our best to work with them to see if we can make that happen. So with that, Carlin is going to pop over on the next screen and actually do a little bit of a demo of within the HIE of one of our newer tools in there and give you a little bit of a capture what it actually looks like. So I'll turn it over to Carlin.
All right. So this is the web-based HIE portal. This is where folks can log in to either search patients for records, but more importantly today, as we were talking about all those different data types and how they feed in and kind of what they could power or look like outside of just looking up Carlin Evanoff and the HIE to see that I had been to the Providence twice. There's a more comprehensive tool called Population Explorer, and I'm going to go ahead and expand this out. So it's all panel based, and that panel just means that it's your known associated patients. So if I work at healthEconnect, all of our known associated patients are going to be on a panel, and that's the only information that I can view in this population, healthEconnect's population-wide tool. So it looks a little busy, and it is, because it has a lot of functionality. So this is a list of everything that's happened on any one of my impaneled patients across our entire data repository. What this empowers you to do is select filters specific to your organizational needs or your patient population needs. So there's a almost limitless list of things that you can filter by. I'm going to focus on a couple of things that I find to be most commonly used. That's admits in the last 30 days. So I can quickly navigate to my entire patient population and apply a filter that will show me everybody who's been admitted to observation in the last 30 days. I could select a filter that said emergency room visits or inpatient visits, or I could have a filter that would say observation, inpatient, emergency room, and curate a list of all of my impaneled patients who meet that criteria. So here would be a list, had I applied this filter, of everybody who had been inpatient or observation in the last 30 days. What we're finding is that, sorry, wow, my brain just stopped. What we're finding is that a lot of FQHCs are looking for a couple of different things, and they've been our highest utilizers of this tool. And it has been social needs that are identified in the emergency room. I know we've talked to maybe some of you in this group about this before. So a lot of times a social need is identified or a social driver of health is identified in the emergency department, and there's not the bandwidth or time, or the acute medical condition is so serious that it hasn't been addressed. Bridging that gap to get that information back to its primary care home was one of our pilot projects that we'll probably I think we have a slide on, we'll talk a little bit about. But it was using this tool to curate that specific data set on their own clients to address needs that were being unmet in the community. There is infinite filters. You can sort by diagnosis. You can sort by like specialty. For example, we have another private clinic who refers a lot of patients to Alaska Heart. They go in, they have a filter set for all their patients that were seen in the last 30 days at Alaska Heart, and they close that referral loop. So there's a lot of different utilizations. It's very organizational specific. And we love to get in here with our end users and work through what filters and exactly what data set they're curating. So this is a really, in some ways, simple and basic, yet extremely powerful tool when you're looking at managing your impaneled patient population. Less applicable to hospital, but I still think really cool and kind of just something that illustrates how we're working to meet the needs of the medical and community-based organization community is the colorectal screening filter now is pulling from different data elements, and is just a pre-built filter where a primary care home can go in, click the colorectal screening filter, and it will populate a list of all performed procedures on their clients so that they can start closing care gaps or reaching out if there's still care gaps that exist for preventative screenings. I could talk all day about this. I'm not really sure how long my allotted slot time was, but from a hospital perspective, for organizations that have a difficult time curating their own data set, if they share data with the HIE, this is a way to go ahead and look at population tools as far as admissions and readmits, and any other like social drivers of health data. I know that there was some reporting requirements around that, but happy to talk more with anybody individually that has any questions about like what does our organization share, what do other organizations share, and could this tool meet this need? All right. Kendra, you still have like a timer or something. I just keep going on and on and on.
No, that's perfect. Do you want to pop to the next slide and then?
I do.
Perfect. You want me to take this or you want to go?
Yeah, I mean, you can go for it. I guess the one thing that I did want to say is that looking at Kendra's going to go ahead and talk about some of this like repository wide, and that's really the power of the HIE, like we've said a million times, is that not only can you look at your own data set, but you can also bump that against care that's happening out in the community. So these are some examples of trends in our repository on the social determinants of health data. And it's been incredible for anybody who was here with us a year or two ago when we looked at this last time. I think it's really cool to follow, but Kendra, take her away.
Yeah, so just to tag on to Carlin, we were kind of, again, it's sometimes thinking about, okay, what would be useful to this group? So just one example, and there's nothing magical about what we selected, but more to kind of give some picture of the types of things that you could be thinking about that we could potentially support with. So this graph, and we have 3 slides that have the same type of information on different Z codes. And so really just looking where these different Z codes are being picked up, the emergency room, outpatient, inpatient setting, and then total. Because it's still relatively new, diagnosis of Z codes, we're also kind of tracking how much the repository is growing over time. That is probably less related to increased occurrence of these different social determinants of health issues, and more that it's really building the data repository, which also helps look that this is going to be valuable data. And again, for organizations who are looking at these, often these social issues pop up in lots of different places. So it's not like they always pop up when they're at their primary care home, or they always pop up. So I think the power of the HIE is we're getting this data from different places, but then when you look at your patients, we could break this down and slice it and dice it in a lot of different ways. We could do this based on patients on your impaneled patients, those types of things. So just kind of food insecurity and unemployment were a couple we looked at. Just kind of interesting how overall it's kind of generally grown over time. Again, May 2023, very, very little Z code data in the repository, and then growing. And then you certainly see also some probably seasonal variation in some of these depending on the Z code, which is interesting. Carlin, if you want to go to the next slide. Again, I'm not going to go through a ton of detail on each of these. We just pulled a few of these problems related to education and literacy and relationship with spouse or partner. So just the types of things and kind of how that has varied a little bit over time. And then we have one more slide with 3 more related to housing and security on the next slide.
Yeah, I'm going to switch.
Carlin, yeah, go ahead. Yep, please.
Even looking at these overviews, I mean, nothing to be gleaned until it's a little further sliced and diced, but it was like, whoa, who was asking this question in the emergency room in May of 24? Like, that's interesting that there was a spike in that being diagnosed. Was it just because those patients? Anyways, I think that it's not only is it interesting just to look at, but as you get down into a more granular, like you're like, oh, we see that the emergency room is always diagnosing this, like maybe resources would be best allocated to addressing this, or, kind of that big picture stuff. And yes, I'll pop to the next slide.
Thanks. Yeah, and I think exactly what Carlin said, really, I mean, as you all are the experts in, it's really about what question are you trying to answer, what problem are you trying to solve, and then how do we think about data elements that could help inform those decisions for you. So some that were just, we pulled out, but again, there's lots of different ways to look at it. This was kind of interesting, just pulled the top 20 Z codes. Again, this is what's in the repository. This is an area that's still growing, and I would probably feel pretty comfortable to say it's not as consistent of how they're diagnosed as other types of, ICD-10 codes. And so there's some variability there, but it is interesting to look at. This is based on unique encounters, meaning that individual patients for that stay that they were in the hospital, as opposed to some of the other data sets, will count a patient twice if they're kind of bouncing around doing different things. But I think, sort of a take home here is that regardless of how you look at the numbers, as probably is not a surprise, homelessness and housing issues are way, way up there on the list. And then sort of that other specified personal risk factors kind of gives also information that that's a fairly generic one. And, as healthcare organizations, do we need to start thinking about how do we help people in more specificity around their diagnoses so that we can take more actionable steps? Because when you have so many that are really generic, it's hard to know how do you really resource that? How do you help start to move the needle on that issue? So kind of looking at what's in there generally, even if you're not relying on the actual numbers themselves, but sort of those trends and how huge of a difference there is in some of the Z codes being, being diagnosed. So those were, again, just a few slides, examples. Carlin, go ahead.
And just to tag on to the other specified personal risk factors not elsewhere classified, when we're looking at big data sets like this, and then we're thinking about how people are using this data to make it actionable, even just like the social drivers of health pilot, where emergency room data was getting back to the primary care home to do outreach, like that wasn't being captured because that wasn't a code that they were looking for. So it was a vague, non-specific code. So if those 8,300 unique encounters were somebody who was inadequate insurance or food insecurities, like because of the vagueness of that diagnoses, like that's not getting passed on or addressed or kind of included in the big picture. I'm saying all things that everybody knows. It just was striking to me that that was at the top. So next slide.
I think this is just kind of a screen capture of exactly what Carlin was talking about, a project report that we did. I'm happy to share the actual report if people are interested, but Matsu Health Services worked with us on a pilot project when we were first starting, kind of trying to figure out what is the power of the Z codes in the repository. We know we have this data here. How can we use it for good? And so they were able to do, and this is the project that Carlin already described, so I won't go into that too much, but really take the Z codes that were diagnosed somewhere outside of their organization on their impaneled patients. And then they had an employee who was working on some outreach who, prior to the pilot, her only way to connect with patients was a warm handoff in the clinic. And this just allowed another tool to be able to figure out which of their patients really could use some social supports that would have impact potentially on their health outcomes. So it was a fun project, and really always appreciative of organizations who will pilot with us when things are new, so that we can kind of tease out where is the utility, where is the value. So that was great. And then the next slide, and I know we're kind of coming up on time and want to make sure there's time for questions, so I'll just hit on one other project we're working on at the moment. Again, wanted to highlight this because it may be something some of your organizations are interested in. We are working with the Alaska PDMP to, the PDMP, we have single sign-on from the HIE, meaning if you're in the HIE, you can get right to the PDMP without logging on separately, but our data don't intermingle. And we know the PDMP is obviously where providers have to look in order to, before they prescribe a controlled substance. So the project we're working on would allow organizations who are a participant of the HIE, so they send us data to say, hey, HIE, could you please also send these non-fatal overdose codes to the PDMP? And so that would allow, and actually the next slide gives a nice picture of it, that would allow the PDMP to display this new window that will show non-fatal overdoses based on diagnosis codes that have been filtered, that have come through the HIE. So it essentially puts data in a provider's workflow that will help them make better treatment decisions when they're doing that, when they're prescribing. So that partnership, if people's organizations are interested, please reach out to me. Essentially, if the organization already is a participant in the HIE, we have an addendum to the participation agreement. The organization signs it, and that's all you have to do. No other data connections, nothing else needs to happen. We just can route that data. So we do all the technical work on our end. We just have to have the agreement signed because the data is under the governance of the organization. And so we need them to tell us what they want us to do with it. But it's an exciting project. And I think one of those things that those partnerships and trying to streamline where data is in workflows to make it efficient for providers or care coordinators or, all the different care team members so that they can use it in the time that's most useful. So I think the next slide is just a little bit of a sort of how the flow of that project of basically how it works. But again, no change to provider workflows or data connections. The connection's already there. We just route the data differently. And if a non-fatal overdose was diagnosed, that's how we would pick it up. So we have a diagnosis code list that would be the qualifying things that would have us send it to the PDMP, and then it would display on that slide, or on that, how the last slide showed on the screen. What was the word I was looking for? On the screen, how the slide showed. So just a project that really wanted to highlight, would love to have participants. We are just getting this off the ground. And really the goal, is to help decrease the number of fatal overdoses. And by picking up on non-fatal, then it might help a prescriber try to decide if they need to do something additional treatment-wise with that patient. So, hoping we can partner to move the needle in that important area. And then I think our next slide is just for questions or comments. Again, we love questions, and we also love things that are on your mind that we can start thinking about how we do trainings, build out tools, all of those types of things. So I'll stop there and we can take questions.
Looks like we had something in the chat. How do I know if my hospital has a signed agreement to route the data to the PDMP?
That is a great question. I can tell you, I do not know what hospital you're from, but I can tell you the answer is no, because we don't have one yet. So I know nobody's does yet. We just started this. And Patricia, I'm not sure what I think Bartlett has maybe verbally agreed to do it, but we don't have it signed yet. So I think we're in the process of, they've said, yes, we just are working through the paperwork piece. And I don't think anyone else is quite there yet. So we'd be happy to talk to anyone and provide that template addendum to the agreement to pass along.
Great question, Trish. Any other questions, or do you want to see have Carlin show us anything else in the portal?
I do have something cool that's just hot off the press, but I'll give it a second for questions while I dig it up again. Ooh, no questions. Okay, so I'm going to share a very primitive screen share today of a report that we're working on that I think is really cool, that will be available in the HIE, and it might be of interest. So it will be Power BI dashboarding that's available to organizations based on the HIE data repository and your patient panel, that will show you revisit and rehospitalization statistics for all of your impaneled hospital patients across all hospitals that share data. So this is a way to get a look at, you can put a bunch of filters. It's not live yet, so I don't have all of the information other than I've just joined a committee and would appreciate any feedback or thoughts that you would have around what would be helpful to have dashboarded around readmissions, knowing that it would be your hospital's patients, but it would look at all hospital admissions across all HIE data contributors and compile analytics and visualization of reports for you all. So that was a lot of my most fanciest words to say we are in the process of building dashboarding around hospital readmissions and hospital data needs. So if there's other reports or visualizations that you are really struggling with, or data gaps out there, looking across your patients' occurrences at other hospitals, please let us know. This is something that we have the opportunity to have input on as it's being built and formulated. So I was just in a meeting about this morning, so I apologize for not having a little more detail and information around it, but I thought it was really cool and something that this group may really be able to help shape for Alaska reporting.
Trish, you put your hand up.
I was looking for my mic.
Ah!
I have a question / potential use case, perhaps. if we could use this data for this purpose. So we thought that we had really awesome readmission data because we were measuring it as if a patient had a full inpatient readmission within 30 days. When we started looking at that differently, to look at patients that had maybe an OB stay within 30 days or an ED visit within 30 days, a very different picture emerged. Would we be able to use this to look for that in certain populations? Like, are our heart failure patients coming to the emergency room a lot, for example, or you have to look by patient? I'm not sure how to use that.
So those are
Okay.
all great questions, and I'm not sure how to use it yet either because we're building it. But what I do know is that you can filter by like discharge disposition. So like where they were sent when they discharged, you can have it inclusive of ER, inpatient, and OBS. You can break that down into just ER, inpatient, or OBS. So there'll be a lot of different ways that you can slice and dice the information on your own patient panel in this tool. It's not just this one view and screen. So what I'm hearing you say is that you need to be able to aggregate ER, inpatient, and observation, as well as view it separately, in addition to being able to slice and dice it by, give me the last piece, because I think I dropped that.
Certain patient populations, like heart failure patients or.
Okay, so like ICD, I think ICD code would probably be reasonable, unless we were identifying them in a different capacity as a heart failure patient.
ICD-10 code, I think would work.
Okay, let me write this down so that I'm including that as well as we're having these kind of technical meetings, and then kind of come back to stakeholders as far as like, this is what we heard, this is what we thought, this is what we're doing. Is this helpful?
Carlin, did you see Angela's question in the chat too? You could probably speak to that.
AHHA be used to track patient outcomes like 30-day mortality, surgical complications. Maybe. I would have to understand where the mortality and surgical complication data lives in order to determine how we could like drill down into it. Are you thinking more of like a broad dashboarding, or are you thinking of like a curated regular report specific to your organization's needs? Because I think that was too many questions. One, let me get more information to answer your mortality and surgical complications question. And then two, if this is something that you feel like would be useful to all hospitals, I can actually definitely pitch it as another dashboarding report. Or does it need to be patient level data? Like, can it be an aggregate report so you can see how you're doing? Or do you need to have it drilled down to the individual patients that had this complication?
Yeah, I can provide a little background. So I'm just thinking about your data repository in terms of when we're looking at provider performance or like practice evaluations. That's a requirement to ongoing evaluate providers. Let's say you have surgeons and you want to know if their mortality rate for their patients that they're doing surgery on is worse or better than another person doing surgery in Alaska. So appendectomy, people have an appendectomy in a small hospital and in Anchorage. Is their post-surgery mortality rate worse in that small hospital than it is in Anchorage? And I don't necessarily, if that's not something that you guys do right now, that's totally fine. I'm just looking for where I can start getting data to be able to compare providers in one location to their performance somewhere else. Because if there's big variation in outcomes between, for example, a small hospital and a large hospital and your surgical mortality rate, that should be a clue that we should be doing something different.
I'm gonna
So it's more of a quality use.
Yeah, no, and I know Carlin's going to answer too. One thing I will say around that area, it's a little bit tricky. There is some language in statute around operations, in terms of, operations is a little fuzzy, like what relates to treatment and treatment outcomes and what is more operations. And this whole issue of, just as you mentioned, looking at provider level information, I think walks on that line that gets a little bit tricky. And full transparency, it also puts the HIE in a little bit of an interesting situation in terms of making sure that we aren't in a place that providers don't want to participate because they are concerned how they will be evaluated based on that data that's there. So it's not, and I can let Carlin weigh in on that too, but I will say things around this area, I think, have walked on this a little interesting line in some of the language that's in statute. So sometimes kind of needing to tease that out a little bit and think about whether the HIE is actually a place, even if it technically is possible to pull that data, whether it's an allowable use for that.
Yeah, I have a much shorter answer. So if the data exists, we can get that specific to your organization. In order to compare it to anybody else's organization, they would have to request it and agree to compare it with you, just because of all the things that Kendra just said about not only statute, regulatory, but also we want to be respectful of the data that's being shared and have it used as in intended purposes. And that's like in that gray area where same way I can't say, oh, I want to see a list of everybody who has breast cancer in Alaska. I can't say, oh, I want to see everybody's mortality rates in Alaska. Good, bad, or indifferent. That's just how things are. But I think that what is more interesting is if you had multiple hospitals who were interested in looking at and comparing their mortality rates, if the data is there, that's definitely something that could be formulated and requested by each hospital. If that was something that AHHA was doing, like, AHHA wide or a few of the hospitals. I guess I should say more interesting, just because I said it's not more interesting. Equally interesting would be if there was a cohort of folks that wanted to look at that together. I think it's doable.
Okay, thank you very much.
Yeah, of course. That was probably way more than you were bargaining for on an answer. We've kept you over.
Are there any other questions for Kendra or Carlin? This has been great. Thank you so much for presenting for us. If you have further questions, feel free to email myself, Debbie, or Carlin and Kendra's emails are in the slide deck that we will send out with the recording of this. Our next session is going to be in July. We don't have a topic yet, so if you have a topic idea or something you want to hear about or something you want to present, let us know. And with that, I will sign off. And there is a quick survey for you to do, which kind of helps us evaluate our session today. So when you sign off, you'll have a quick Zoom poll to take. Thank you, everyone, for coming today.
Thank you guys so much.
Thanks, everyone. Thank you.